topic of discussion for today is going to be neurology, and this is going to be part one. Bear with me if neurology is not very familiar to you, the lecture might be a bit too intense, although I've tried to the best of my ability to make it as simple as possible. And in case there is any point in time that you feel you need clarification, you can feel free to stop me anytime. The first question is asking, what does bilateral vestibular schwannomas indicate? Okay, and this is what we are referring to. These are schwannomas. This is an MRI of the head, and it's basically showing us two masses or two tumors within the cerebellopontine angle. These are referred to as vestibular schwannomas. What do they indicate? Is it neurofibromatosis type 1 or type 2? Is it multiple sclerosis or ALS? Okay, so the right answer here is neurofibromatosis type 2. Okay, so neurofibromatosis type 2 is one of those neurocutaneous syndromes that is characterized by bilateral vestibular schwannomas. Okay, so these are tumors of the Schwann cells. Schwann cells are supposed to lead to myelination of the peripheral nervous system. And for patients who have neurofibromatosis type 2, one of the complications that they might end up getting is bilateral vestibular schwannomas. So whenever you see description like that, make sure you pick neurofibromatosis type 2, because typically for patients who do not have neurofibromatosis type 2, they're just going to have one schwannoma, if at all they have a schwannoma. But if it's bilateral, think about neurofibromatosis type 2. And then the other name of these tumors is acoustic neuromas. So patients typically are going to present with features suggestive of these tumors. They include things like hearing loss, tinnitus, and balance. And the reason why this happens is because these tumors are located very close to the vestibular and the cochlear nerve. Those nerves in combination, they are required for both hearing and balance. So any tumor that might be close to that particular region might affect them, leading to the said features. The other thing that we need to know with regards to neurofibromatosis type 2 is that it's found on chromosome 22. Okay, so the other name for neurofibromatosis type 2, according to me, is the neurofibroma of twos. Okay, where you have two schwannomas, chromosome 22. Okay, and then the other thing that we also need to remember is that it's related or it's associated with two other tumors. There is meningioma and ependymoma. Okay, all right, so that's why I call it the neurofibroma of twos. Okay, two schwannomas, chromosome 22, and then two other tumors. Okay, and specifically neurofibromatosis type 2 is caused by mutation in the myelin gene, which is a tumor suppressor gene. Okay, the mode of inheritance of this condition is autosomal dominant, and this is usually a very common mode of inheritance for the vast majority of the neurocutaneous syndromes. Okay, and then the other thing that you also need to know with regards to this condition is that it has very few skin findings. This is in contrast with neurofibromatosis type 1, which is characterized by a wide array of skin findings that we are going to discuss in a few. Okay, and this is just an image showing us a meningioma. Alternatively, the other way that you can test neurofibromatosis type 2 is by showing you the associations. Okay, they might tell you that a patient has maybe hearing loss and balance issues, and then in addition, this is the finding that they figured out on imaging. You put that clinical picture together, you come up with a diagnosis of neurofibromatosis type 2. Okay, so what about neurofibromatosis type 1? It's found on chromosome 17. Okay, and it's specifically caused by a mutation in the neurofibromin gene. Okay, and then the other thing that we also need to know is that it has different skin findings. One of the most important ones is cafe au lait spots. Okay, and they also have neurofibromas. So skin findings are typical of neurofibromatosis type 1, not of type 2. The feature that it has is leash nodules. These are the pigmented iris hematomas that are being shown by the arrows. Okay, associated with optic gliomas, pheochromocytomas, and scoliosis. Okay, but remember, for neurofibromatosis type 1, it's leash nodules, very important, optic glioma, and pheochromocytoma. Okay, and then for neurofibromatosis type 2, remember it was only two, meningiomas and ependymomas. okay, in addition to the acoustic neuromas. Right, we have another question here. We have a 25-year-old female with sudden painful right eye vision loss. There is a sensation of electric shock down the spine when the neck is flexed, and the following is the MRI for that particular female, MRI of her head. Okay, and we can see different periventricular white matter lesions. Okay, they are found along the edges of the ventricle, hence the name periventricular. What is the diagnosis for this patient? Is it GBS? Is it multiple sclerosis? Is it transverse myelitis? Or is it vitamin B12 deficiency? So the right answer in this case is multiple sclerosis. Okay, so multiple sclerosis is a condition that is characterized by demyelination within the central nervous system. It's very important to know that the demyelination in MS occurs in the central nervous system, and that demyelination is caused by an autoimmune process whereby T cells destroy oligodendrocytes. Now, oligodendrocytes are cells found within the central nervous system whose main job is to myelinate those nerves. So if they are destroyed, what we end up getting is demyelination of the central nervous system, and it leads to different manifestations. Let's look at some of the manifestations from the question itself. We can see that this female has sudden painful right eye vision loss. This is what we refer to as optic neuritis, and it's one of the most important high-yield findings for patients who have MS, okay? And MS is more common in females. The other finding is the sensation of the electric shock. This is referred to as Lemaitre sign, okay? And then obviously the MRI findings that I described of the periventricular white matter lesions. The other things that we need to add with regards to MS is that the symptoms are separated in time and space. Okay, and then it has this very important pattern, the relapsing remitting pattern, and this essentially means the symptoms are going to get better, get worse, get better, get worse. Okay, so there is relapsing, there is remitting of the symptoms. Okay, and most of the time it's going to worsen with heat. This phenomena is called the Harthoff phenomena. They also have what we refer to as intranuclear ophthalmoplegia. Intranuclear ophthalmoplegia, and for this condition, it's characterized by impaired adduction of one eye. So one eye is not able to adduct, okay? Plus the other eye has contralateral nystagmus, okay? Now, they love asking for MS, they love asking the intranuclear ophthalmoplegia is being caused by what? And it's usually caused by the medial longitudinal fasciculus lesion. Okay, it's basically demyelination of MLF, which is going to lead to the intranuclear ophthalmoplegia. And then on CSF study, we are going to see oligoclonal IgG bands. Okay, all of that is very high yield for MS. All right, let's look at the next question. There is a 30-year-old man who develops ascending symmetric weakness and absent reflexes 2 weeks after diarrhea. What is the most likely CSF finding? Okay, what is the most likely CSF finding? So this patient has what we refer to as GBS, okay? Guillain-Barré syndrome. Guillain-Barré syndrome is characterized by a very unique finding, okay? Ascending symmetric weakness, okay? Typically starts from the legs and then spreads upwards, okay? And they also tend to have loss of reflexes, and the trigger is usually an infection, okay? And most of the time the infection is caused by Campylobacter jejuni, okay? Now for the CSF, we are going to see increased protein and normal WBCs, increased protein and normal WBCs. And the reason why this happens is because GBS, remember, is an autoimmune condition. So typically we do not expect any WBCs to increase because most of the time WBCs increase in response to infection. So considering there is no infection, then it makes sense for WBCs to remain normal. But proteins are going to increase because GBS is characterized by an inflammatory response. Okay, so and usually proteins are increased during inflammation. Okay, so the above CSF finding of high proteins and normal WBCs are what we refer to as albuminocytologic dissociation. Albumin cytologic dissociation. Okay, so most of the time when there is infection, we expect proteins as well as WBCs to increase. But when there is only increase in albumin, okay, which is a protein, and the cells which are WBCs remaining normal, then there is going to be a dissociation, hence the name albuminocytologic dissociation. GBS is an autoimmune condition that leads to demyelination of the peripheral nervous system, and specifically it involves the Schwann cells. Remember, MS on the other hand was demyelination of the central nervous system. That distinction has to be understood very clearly. And most of the time, GBS is going to follow an infection, particularly of Campylobacter jejuni, which is a GI infection, but it can also follow other infections like the respiratory tract. Okay, and typically the timeline is like 2 to 3 weeks after an infectious condition. Okay, a reflexia is also going to be there, like we said, and then they also love asking what are some of the complications that might arise in patients who have GBS, or alternatively, which is a common cause of death in patients who have GBS if it's not managed properly, in which case respiratory failure is the right answer. Okay, and the reason for that is because the weakness spreads upwards, okay, and it can end up affecting the diaphragm, hence the respiratory failure. Right, what condition is characterized by ash leaf spots? These ones here, okay, which can be described as hypopigmented macules and seizures. Okay, this combination is typical of tuberous sclerosis. Tuberous sclerosis is also one of the neurocutaneous syndromes. It's inherited in an autosomal dominant fashion. Okay, and the genes affected specifically are TCS1, which is the harmatin gene, or TCS2, which is the tuberin gene. Okay, and also these genes are tumor suppressor genes, and they might also add the fact that those genes, if they are mutated, they are going to lead to loss of inhibition of mTOR. Okay, mTOR is one of those signaling pathways. Now, but you don't really need to know the specifics. Just know that TCS mutation is going to lead to loss of inhibition of the mTOR signaling pathway. What are some of the other manifestations of tuberous sclerosis? Basically, simplify them by the mnemonic ash leaf to remind us that ash leaf spots are actually one of the most important findings for those patients. And A in the mnemonic is going to stand for ash leaf spots. S is for chagrin patches, and these are those patches. Chagrin patches, in other words, they are going to be described as leathery skin abnormality, as you can see over here. H is heart rhabdomyosarcoma. Okay, heart rhabdomyosarcoma. L is for lung hematomas. E is for epilepsy from cortical tubers. Now, another question that might arise for tuberous sclerosis is, what is the earliest manifestation of tuberous sclerosis? And typically the answer should be seizures. Seizures are the ones that come up the earliest. Okay, A is angiomyolipoma in the kidney, and then F is facial angiofibromas. Okay, so take a bit of time to go through that mnemonic, and with that you'll be good to go for tuberous sclerosis. The next question is asking, we have a finding of a lens-shaped hematoma on CT in a patient with initial loss of consciousness after a motor vehicle accident. The patient has temporary improvement of their symptoms with rapid deterioration right afterwards. What is the right diagnosis there? A, subdural hematoma, B, epidural hematoma, C, subarachnoid hemorrhage, and then D, intercerebral hemorrhage. Okay, so this is a very common question, and the right answer here should be epidural hematoma. This is what it typically looks like. It's lens-shaped. Okay, it's lens-shaped. It's common after trauma, like after a road traffic accident, and then the fact that there is temporary improvement and rapid deterioration of the patient's symptoms is very typical of epidural hematoma. Okay, that is what we refer to as a lucid interval. A lucid interval, very high yield. Another question they love asking is, which artery or which blood vessel is implicated with regards to formation of the hematoma? And the right answer is usually middle meningeal artery. Middle meningeal artery. The other kind of hematoma that we need to know for the brain is the subdural hematoma. The subdural hematoma has this crescent or banana shape. Okay, remember for epidural it was lens shaped, but for this one it's crescent or banana shaped, and the vessel here is usually the bridging veins, not an artery but a bridging vein, and it's more common in alcoholics, in elderly patients, as well as anticoagulated patients. Okay, patients who are, for example, on warfarin. Next question is asking, we have a 55-year-old woman who presents with sudden severe thunderclap headache, neck stiffness, and photophobia. CT head shows blood in the subarachnoid space. What is the most likely cause? A, ruptured perianeurysm, B, epidural hematoma, and C, subdural hematoma. Okay, and this is the CT finding right here. This is where the subarachnoid space is, and this is where the blood is accumulating. Okay, does anyone want to unmute and maybe tell us the answer to this question? I think it's pretty straightforward.
Subarachnoid hematoma.
Yes, subarachnoid hemorrhage. A, B, and C, which should be the right answer?
Ruptured
Ruptured perianeurysm.
Yes, ruptured perianeurysm. Okay, ruptured perianeurysm usually is located within the vessels within the circle of Willis. Okay, and let me take this opportunity to go through the structure of the circle of Willis. Okay, so for the circle of Willis, remember it's two systems. It's the vertebral system and then the carotid system. Okay, so the vertebral system is formed by the vertebral arteries, which are these two here. We have the right and the left. Okay, they are going to supply it from downwards. Okay, and then the carotid system is the internal carotid, which is going to have branches like the middle cerebral, the anterior cerebral right here, and then the anterior communicating right there. Okay, there are also different other smaller branches, but I'm just going to focus on the big ones. Okay, and then for the only other branch that we haven't mentioned for the carotid system is the posterior cerebral artery. So those are the big three branches of the carotid system. And then for the vertebral system, we can have different branches like the anterior inferior cerebellar artery and then the basilar artery, as well as the superior cerebellar artery. So those two systems, the carotid and the vertebral, they're going to come together to form the circle of Willis. And the reason why the circle of Willis is important is to provide redundancy. So in case there is a problem with the vertebral system, we have another system, which is the carotid system, that is going to supply blood to the brain. That is the circle of Willis in a nutshell. Now, the anterior communicating artery can have aneurysms. Aneurysms are basically dilation of blood vessels, okay, usually an artery, and unfortunately those dilations can rupture. Okay, and the anterior communicating artery is a common location of those aneurysms. Okay, and those aneurysms unfortunately can rupture, leading to a subarachnoid hemorrhage. Also, the posterior communicating artery can have aneurysms which can also rupture, leading to a subarachnoid hemorrhage. Now, the difference between those two arteries is that for patients who have aneurysms of the posterior communicating artery, for them, if they get a subarachnoid hemorrhage, it tends to be more fatal compared to the one for the anterior communicating artery. Okay, but typically the anterior communicating one is way more common but less deadlier. We have some risk factors for a subarachnoid hemorrhage. They include connective tissue diseases like Marfan syndrome, Ehlers-Danlos syndrome. Okay, and we can also have autosomal dominant polycystic kidney disease, which can lead to formation of those aneurysms. Okay, so the way they test this question, okay, or this association with autosomal dominant polycystic kidney disease is they'll give you a patient who has, they'll tell you that the patient is hypertensive, okay, and then on imaging of their kidneys, okay, ultrasound imaging of their kidneys is going to show multiple cysts in their kidneys. Okay, and then they'll ask, which of the following condition is this patient at risk of developing in future just because of their diagnosis? Okay, and in which case one of the possible answers is a perianeurysm or a subarachnoid hemorrhage. Okay, and then the other complications of a subarachnoid hemorrhage is actually vasospasm of the blood vessels within the brain, leading to ischemia. And typically this ischemia is going to occur 3 to 14 days post the subarachnoid hemorrhage. Okay, post the subarachnoid hemorrhage. And they love asking, how do we prevent that vasospastic activity? In which case the right answer should be imodipine. Imodipine is one of the calcium channel blockers. Okay, so let me just do another run through of subarachnoid hemorrhage with regards to the manifestations. Subarachnoid hemorrhage is a condition that is very painful. Okay, so patients are typically going to complain of the worst headache of their life. That is another way they love phrasing for subarachnoid hemorrhage. Okay, and then the blood that is going to be spilled into the subarachnoid space is actually going to irritate the meninges, so patients can have neck stiffness. They can also develop photophobia. Okay, they can also develop photophobia. Another high-yield concept that we also need to remember for subarachnoid hemorrhage is that there is what we refer to as xanthochromia, which is finding of blood on doing a lumbar puncture. Okay, that is also another thing they might bring up. Right, next question. The 2-year-old woman presents with recurrent unilateral pulsating headache that is associated with nausea, photophobia, and phonophobia, and the attacks last anywhere from 4 to 72 hours. What is the diagnosis? A, tension type headache, B, migraine headache, C, cluster headache, D, subarachnoid hemorrhage, and then E, temporal arteritis. This is also a pretty straightforward question. Kindly unmute if you know the answer and tell us.
Migraine headache.
Yes, the right answer is migraine headache. And acutely, how do we manage migraine headaches?
Triptans.
Yes, triptans. And for prophylaxis, we use the following: propranolol, which is a beta blocker. This is the one that is most commonly used, but you can also use topiramate and valproic acid. Okay, so for migraine headache, the fact that it's unilateral, it's pulsating, is very important. Okay, is very important. And then the other associated features can be photophobia and phonophobia. Now, the only thing that might have not been mentioned for this particular condition is that it can have an aura, and aura can include things like maybe nausea, vomiting, blood vision, okay, or change in their sense of taste or smell. And then it's also more common in females. All right, we have another question here. We have a 40-year-old man who presents with severe unilateral periorbital pain. The episodes last 15 to 180 minutes. They occur multiple times a day, and sometimes they are severe enough to wake him up. The patient also has tearing, conjunctival injections, and nasal congestion. Okay, what is the diagnosis? It's a type of headache. It's not migraine. Which type of headache is this? Kindly unmute if you know the answer.
It's a cluster headache.
Yes, this is a cluster headache. Cluster headache is also unilateral, similar to migraines. Okay, and also very important, the location of periorbital is very important. The other way they can phrase this is, they'll tell you it's like temporal or it's behind the eye. Okay, and with cluster headaches, it occurs a couple of times per day. Okay, and it's excruciating pain, so bad to the point that it can wake up a patient. And there is also an association with autonomic manifestations like tearing, okay, salivation, conjunctival injections, and nasal congestion. So when you see that particular clinical picture, think about cluster headache. Acutely, we manage it using triptans, similar to migraines. But for patients who are not responding very well to that particular medication, we can escalate our treatment and move on to 100% oxygen. Okay, 100% oxygen is very good for management of cluster headaches acutely. And remember, this is a very painful condition. Okay. And then for prophylaxis, we can use verapamil, which is a calcium channel blocker. Verapamil is for cluster headaches, and then propranolol, which is a beta blocker, is for prophylaxis of migraine headaches. The next question is we have a 28-year-old woman who presents with bilateral pressing, tight band-like headache that occurs throughout the day. Okay, she also has shoulder and neck pain. What is the diagnosis here?
Tension.
Yes, this is tension type headache. Tension type headache is going to be typically after a long day, after a long stressful day, and it's going to be bilateral. Remember, the previous two were unilateral, and they usually describe it as tight band-like, okay, and it can lead to tension in the shoulders, in the neck, okay, sometimes even in the back, okay, and management is PCM, which is paracetamol or NSAIDs. Which seizure type is associated with a 3 Hz spike wave EEG in a 5-year-old girl who has staring spells lasting between 5 to 10 seconds. And in addition, she has lip smacking and it can be provoked by hyperventilation. Is it absence? Is it tonic-clonic? Is it myoclonic? Or is it focal seizure? Does anyone have a clue?
Absent.
Yes, this is absence seizure, and absence seizure is the one that is characterized by the 3-hertz spike. This is a very specific EEG finding for absence seizures, and it tends to affect children, typically below the age of 10, okay? And they're going to have these staring spells that occur a couple of times in a day, and usually it's like the teachers who recognize them early, and they're going to describe the child like not paying attention in class, or yeah, something like that. And then they have what we refer to as automations, like lip smacking, okay? And for some, it can be provoked by a hyperventilation episode, okay? For medication, it's very specific. It's ethosuximide. Ethosuximide is very high yield. It's basically the first line for absence seizure. It's a calcium channel blocker, and if ethosuximide is not efficient enough, then we can move on and give them valproic acid. But the rest of the anticonvulsants are usually contraindicated for ethosuximide, for absence seizures, because they tend to worsen it. Okay, and then if they ask about prognosis, most of the time these children are going to outgrow these seizures by the time they become adolescents. So it tends to go away with age. Okay, next question is of a 58-year-old man who presents with progressive muscle weakness in his hands and his forearms. The patient has muscle cramps and fasciculations. On examination, he has spasticity, hyperreflexia in his legs, as well as atrophy of his hand muscles. Sensory exam is normal. What is the diagnosis? Is it multiple sclerosis? Is it myasthenia gravis? Is it amyotrophic lateral sclerosis? Is it GBS, or is it peripheral neuropathy? And it might be difficult, but what we are looking for here is a combination of upper motor neuron and lower motor neuron lesions. Does anyone have a clue what the right answer in this case should be?
C.
C, yeah, this is ALS, amyotrophic lateral sclerosis, which, like I said, is a combination of upper motor neuron lesions. Okay, upper motor neuron lesions like the hyperreflexia and the spasticity, and then the lower motor neuron lesions, manifestations like the atrophy or the fasciculations or the muscle weakness. And then, very important, ALS purely affects the motor system. Okay, it does not affect the sensory system in whatsoever. Hence, the normal sensory exam. That is very important to know. Okay, and then they might ask, what is the specific mutation in ALS? And it's typically the SOD1 mutation, which in full is the superoxide dismutase mutation. And for management, we typically use riluzole, but this riluzole is only going to slow down disease progression. It's not going to really cure it altogether. It's just going to slow the disease progression. And pathophysiology, they might also ask this, is due to degeneration of corticospinal tracts, which is going to be responsible for the upper motor neuron manifestations, and degeneration of the anterior horn cells, which is going to be responsible for the lower motor neuron lesion manifestations. We have a patient who presents with a triad of ptosis, meiosis, and hydrosis. Which structure is affected? Is it the upper cervical sympathetic chain? Is it the cranial nerve number 3? Is it subthalamic nucleus? Is it the basal ganglia? This is Horner syndrome. Horner syndrome is a triad of ptosis, meiosis, and hydrosis, and it's usually due to the cervical sympathetic chain, okay, that are affected. We have a patient who has impaired adduction of the right eye with nystagmus of the left eye when looking left. What lesion is the most likely cause of the findings? Is it right medial longitudinal fasciculus? Is it the left corticospinal tract? Is it cranial nerve number 6, or is it the cranial nerve number 3? Okay, and a clue, this patient also has MS, multiple sclerosis. Okay, what do you think is the right answer in this case?
Right medial.
Yes. Yes, the right MLF, right medial longitudinal fasciculus. If it's damaged, it leads to what we refer to as internuclear ophthalmoplegia, which is going to manifest typically with the impaired adduction of the right eye and the nystagmus of the left eye, okay, or nystagmus of the contralateral eye. right? And it's very common in MS. It can also occur in patients who have a stroke.
Sorry, just clarification. You've said if
Mhm.
the right MLF is affected, you won't be able to adduct the right eye.
Right eye, yes. And then Mhm.
So it's the same
same
side.
same side, and then nystagmus of the opposite side.
Oh, okay. Thank you.
Welcome. Right, the next question is very easy. Which deficit is typical of an anterior cerebral artery stroke? Is it contralateral leg weakness, more than the arm weakness? Is it contralateral face weakness? Is it contralateral visual field loss? Or is it ipsilateral facial droop? For this one, I would want you to maybe go through each and every choice and tell us which specific artery, if it gets a stroke, would present like that. Okay, anyone who wants to volunteer? Go ahead.
I think it is A. The
Mhm.
anterior cerebral artery supplies the contralateral side and it affects the legs. So leg weakness would be the problem. Contralateral face weakness would be the middle cerebral, I think.
Mhm.
Contralateral visual loss. Visual is occiput, posterior cerebral.
Mhm.
Ipsilateral facial droop. This one I'm not sure.
This is most likely a brainstem problem. Okay, so for the cortical problems, they are going to be contralateral. Okay, and then anything below the cortex is going to be ipsilateral. So it can be anywhere from maybe the brainstem to the actual facial nerve, anywhere along that pathway. Okay, it can lead to ipsilateral facial droop. Right. I think you can also answer this question for us, which is the most commonly affected, which is, oh, wait, let me do justice to the above question, in some of the other manifestations of anterior cerebral artery stroke apart from the leg weakness. Apart from the leg weakness, for anterior cerebral artery stroke, we can also have loss of urinary continence, so patients are going to be incontinent. Okay. Yeah. And then for the middle cerebral artery, apart from the facial weakness, they can also have arm weakness, but they can also have problems with their speech. Okay, they can also have what we refer to as hemi-neglect. Okay, those are the most important findings for the named arteries. Okay, so which is the most commonly affected? Which is the most commonly affected in middle cerebral artery stroke? Face and arm weakness over leg weakness. Face and arm over leg weakness, this should be the right answer. Leg over arm weakness, this is for the anterior cerebral. And then C, visual field only, this is going to be posterior cerebral artery. And then for balance only, it can be maybe the brainstem or the vestibulocochlear nerve, or even the cerebellum. Okay, a patient has intention tremor, dysmetria, and a wide-based gait. Which lobe is affected? Is it the cerebellar hemisphere? Is it the vermis? Is it the basal ganglia or the subthalamic nucleus? Does anyone have a clue? And just knowing that the patient has intention tremor or dysmetria is enough to know the right answer in this case. Well, the right answer here is the cerebellar hemisphere. Okay, so when you see intention tremor, think about the cerebellum. When you see dysmetria, think about the cerebellum. Okay, patient presents with truncal ataxia and difficulty walking. What is the right answer? For which is the source of the lesion? It's going to be the vermis. Okay, vermal problems are going to be characterized by truncal ataxia. Truncal ataxia for the vermis plus difficulty walking, but truncal ataxia is a lot more specific for the vermis. A patient has non-fluent speech with preserved comprehension. Which artery is likely affected? Is it the MCA? Is it the ACA, PCA, or the basilar artery? Okay, and clue, what we're describing here is expressive aphasia. What is the right answer?
MCA.
Yes, MCA. For production of speech, we have the motor area, okay, which is referred to as the Broca's area, which is very essential for expressing language, okay. And then we have Wernicke's area, which is very important for understanding language. So for language, we typically need to have a combination of those two. Okay, Broca's area for production of speech, and then Wernicke's area for understanding language. When they mention a patient having non-fluent speech, okay, that is typically referring to a motor problem, okay, a production of speech problem. While we're on this slide, let me take this opportunity to also discuss some of the other brain areas. We have the frontal lobe, which is the area that is required for higher functions like planning, organizing, emotional stability, determination, etc., etc. So the frontal lobe is sort of like the newest part of our brain evolutionarily, and it's the one that is very important, and it sort of like defines us as humans because of our capacity to think and plan. Okay, and then for the temporal lobe, it has different structures within it. It has structures for taste, it has structures for hearing. And the occipital lobe is basically for vision. Then the parietal lobe is mostly important for perception and spatial awareness. Okay, perception and spatial awareness. Hence, the reason why patients who have parietal lobe problems will end up getting what we refer to as hemi-neglect. Okay, and then the other structures found within the frontal lobe, that like the primary motor area, is required for initiation of movement, and then the somatosensory cortex within the parietal lobe is required for sensation. Okay, so lesions of the Broca's area are going to lead to what we refer to as expressive aphasia. Expressive aphasia. Okay, and the middle cerebral artery is required for blood supply to both the Broca's area and the Wernicke's area. Okay, so I want you guys to follow me. You see this entire area right here, okay, where I am circling around right there. That is the area that is supplied by the middle cerebral artery. So all of this. Okay, and then the anterior cerebral artery is usually around here, right, just above here, and then the posterior cerebral artery is usually just around here towards the end. A 62-year-old man suffers a left middle cerebral artery stroke. He is fluent in speech, but his sentences lack meaning, and he has impaired comprehension of spoken language. Which brain area is most likely affected? A, Broca's area; B, Wernicke's area; C, arcuate fasciculars; D, primary motor cortex; and then E, angular gyrus. What should be the right answer in this case? Any one of you can unmute.
Wernicke's area.
Yes, this is Wernicke's area. This patient has what we refer to as receptive aphasia. They have fluent speech, which means the motor aspect of speech is intact. Okay, but when they speak, their sentences do not make sense. Okay, which means there is a problem with comprehension when they're trying to form sentences. Okay, and that is usually a Wernicke area problem. Okay, I'm going to skip arcuate fasciculars for now. Okay, and then I've already mentioned the primary motor cortex is required for initiation or planning of movement, and then the angular gyrus is required for calculation. Okay, so a lesion of the angular gyrus would lead to what we refer to as a calculia. Okay, we have another related question. A 50-year-old right-handed man suffers a stroke affecting the left hemisphere. He understands speech and can speak fluently, but repeats words and phrases poorly. Which structure is most likely damaged? A, Broca's area; B, Wernicke's area; C, arcuate fasciculars; D, primary motor cortex; and then E, angular gyrus. Okay, well, the right answer in this case is arcuate fasciculars. Arcuate fasciculars is a group of nerves that connects the Wernicke's area and the Broca's area. Okay, Broca's area. So these patients are going to be fluent. They're going to be understanding speech. The only problem is repetition of words and phrases. So repetition, if it's the only problem in their speech, think about or arcuate fasciculars, which is going to lead to what we refer to as conduction aphasia. Conduction aphasia. Next question. 28-year-old woman presents with ptosis, diplopia, and progressive muscle weakness that worsens later in the day and improves with rest. Which of the following is the most likely mechanism of heart disease? A, autoimmune destruction of muscle fibers; B, autoantibodies against acetylcholine receptors at the neuromuscular junction; C, autoantibodies against voltage-gated calcium channels; D, demyelination of peripheral nerves, and then E, degeneration of anterior horn cells. What do you think is the diagnosis first and then the right answer in this case?
Myasthenia gravis,
Yes, why do you think it's myasthenia gravis?
because of the ocular problems, the ptosis, the diplopia, and progressive muscle weakness that worsens later in the day
Mm-hmm.
and improves with rest. Yes.
Mm-hmm. So what is the right answer in this case?
It's autoantibodies against acetylcholine receptors at the neuromuscular junction.
Yes, that is the right answer. What about C? What do you think C is referring to? And it's closely related to myasthenia gravis.
Eaton Lambert?
Yes, yes, absolutely. And then D, I think we've done D already.
GBS.
GBS, and what else? Oh yeah, it's only GBS, sorry. Yeah, GBS. What about E? Generation of anterior horn cells. It can be caused by different conditions. Example, polio. Another example,
ALS.
ALS. Yes. And then A, autoimmune destruction of muscle fibers.
Myositis.
Polymyositis and dermatomyositis can also lead to that. All right. So the previous question was on myasthenia gravis, and these are the following. The following are the high-yield concepts we need to know. So myasthenia gravis has an association with thymoma or thymic hyperplasia. Okay, so a problem of the thymus gland. So whenever we get a patient with myasthenia gravis, it's very important to follow up with an imaging of their chest, typically like a CT, to make sure that the patient does not have a concurrent thymic hyperplasia or thymoma. Okay, and typically this is what we expect to see, and usually that is the right answer. When they ask, once like you've established the diagnosis of myasthenia gravis, if they ask what is the best next step in management for this patient, it's usually to do a CT, okay, to check for a thymoma, and if it's present, then we can go ahead and resect it, and then typically the symptoms are going to go away once the resection is done. Okay, so for diagnosis, we need to do acetylcholine receptor antibodies. This is like the gold standard. Okay, not the initial test. The initial test is the ice pack test. For the ice pack test, they're going to tell you that an ice pack was used for that particular patient, typically around the eye, with now improvement of their symptoms. Okay, and this condition is characterized by the acetylcholine receptor antibodies against the acetylcholine receptor. Okay, I know it's redundant, but it's antibodies against that acetylcholine receptor, which is going to now mess around with the neuromuscular junction, leading to loss or weakness in their motor functions as the day progresses, and then once they rest, then there is going to be major improvement in their functions. Okay, and then for treatment, we can give them acetylcholinesterase inhibitors like pyridostigmine. Okay, pyridostigmine. There was an older test of the hydrophonium test, which is not typically done anymore. Okay, and then these patients have a high risk of developing what we refer to as myasthenic crisis, and this is when there is acute and severe worsening of their symptoms, leading to weakness that is widespread, leading to even respiratory failure due to weakness of their diaphragm. Again, this can be life-threatening. And some of the triggers of myasthenic crisis are things like infection, surgery, or certain drugs. So typically, it's acute stressors to the body might trigger myasthenic crisis. Okay. A 60-year-old man presents with proximal muscle weakness in their hips and shoulders, and improves with repeated activity. He has dry mouth, constipation, and a workup reveals a small cell lung carcinoma. So the following best describes the pathophysiology of his neuromuscular weakness. A, autoantibodies against postsynaptic acetylcholine receptors. B, autoantibodies against presynaptic voltage-gated calcium channels. C, botulinum toxin mediated inhibition of acetylcholine release. D, demyelination of peripheral nerves. And then E, degeneration of anterior horn cells. What do you think the right answer in this case is?
Boy, autoantibodies against presynaptic voltage-gated channels, calcium channels.
What is the diagnosis?
Lambert-Eaton
Yes.
myasthenic syndrome.
Yes, the patient has Lambert-Eaton syndrome, and Lambert-Eaton syndrome is characterized by those antibodies against the calcium channels found presynaptically. Okay, and it has a very high yield association with small cell lung carcinoma. It's one of those paraneoplastic syndromes of small cell lung carcinoma. Okay, remember for some cancers, for the purposes of step 1 and step 2 USMLE, we need to know their paraneoplastic syndromes. Okay, and specifically for small cell lung carcinoma, one of the findings is usually Lambert-Eaton syndrome. Can anyone mention maybe one or two other paraneoplastic syndromes of small cell lung cancer?
Yes, Bartholin hormone releasing.
Syndrome of inappropriate age.
All right, thank you for that. All right, so typically Lambert-Eaton is going to improve with repeated activity. Okay, and unfortunately I forgot to put it in this set of slides, but for Lambert-Eaton we are going to see, they're going to give you, I'm forgetting the name of the study, it's some kind of is it neuro something study? I'm forgetting the name of the study, but they're going to show there is improvement of muscle activity with repetition. Then for treatment, we give what we refer to as 3,4-diaminopyridine. Okay, 3,4-diaminopyridine, whose mechanism of action is actually to increase acetylcholine release presynaptically. Right. Next question is, a 62-year-old man presents with resting tremor, rigidity, bradykinesia, and shuffling gait. So the following is the primary pathology in this disease: a loss of dopaminergic neurons in the substantia nigra pars compacta.
Excuse me, doctor.
Yes.
I beg your pardon, or my colleagues, about the paraneoplastic syndromes of Lambert-Eaton. Like they mentioned some, I didn't catch them.
Okay, so we have, for small cell lung carcinoma, we have three of them. We have SIADH, we have Lambert-Eaton syndrome, and then we have Cushing syndrome. Okay, ACTH production. Those three are for small cell lung carcinoma of the lung. And then for the squamous cell lung carcinoma of the lung, we can have hypercalcemia secondary to parathyroid hormone related protein. Okay, and then for the other lung cancer, we have the large cell carcinoma whose paraneoplastic syndrome is gynecomastia in males. And then the other one, the adenocarcinoma, its paraneoplastic syndrome is hypertrophic osteoarthropathy. Okay, usually it's the lung cancers, they love asking their paraneoplastic syndromes.
Thank you.
You're welcome. All right. Sorry, I forgot and showed you guys the answer. Right. So A is saying loss of dopaminergic neurons in the substantia nigra pars compacta. B is autoimmune destruction of myelin in CNS. C is loss of lower motor neurons in the anterior horn. And then D is autoantibodies against acetylcholine receptors. And E is loss of Purkinje cells in the cerebellum. Who knows the right answer in this case?
It is A.
A. What is the diagnosis for this patient?
For Parkinson.
Yes, Parkinson's disease. So Parkinson's disease has the above mentioned manifestations, and we can remember them by the mnemonic TRAP. Yes, T for tremor, and typically it's a rest tremor, not an intention tremor. An intentional tremor is found mostly in cerebellar issues. And then R is for rigidity. A is for either akinesia or bradykinesia, which is like difficulty in initiation of movement. And then P is postural instability. So they typically have what we refer to as a shuffling gait. Okay, TRAP. Okay, in addition, they can have depression, they can have dementia, okay, and they can also have sleep disturbances, particularly affecting their REM sleep. Okay, and then histologically, they have what we refer to as Lewy bodies. Okay, Lewy bodies, which are intracytoplasmic alpha-synuclein inclusions. And then for management, Parkinson's disease can be managed by a wide array of medications, which I do not really have the time to mention right now. in like conclusively, but the most common one is usually levodopa, carbidopa, okay, and it's usually the most effective for management of bradykinesia and rigidity, okay. And then remember, for USMLE step 1, we need to know the mechanism of action of these medications and their common side effects, okay. So any of the medications that you're going to learn about, make sure you know those specifics, okay, particularly the ones that are really unique, okay. So for levodopa, carbidopa, I'm going to mention one unique finding, which is they have what we refer to as an on and off phenomena, whereby they have good response and then worsening of their symptoms, good response to the medication and then worsening, okay. That is typical of levodopa and carbidopa. And then the other medications that can also use are dopamine agonists like pramipexole and ropinirole. Right, but we have so many other medications as well. We have entacapone, tolcapone. There are so many other medications. Make sure you know their, like, in which part of the dopamine cycle within the brain that they are specifically used. We have a 35-year-old man who presents with chorea, progressive dementia, and personality changes. His mother had similar symptoms starting at 45. And then which of the following is the most likely genetic defect for the findings? A, trinucleotide CAG repeat expansion in the HTT gene, trinucleotide CTG repeat expansion in the DMPK gene, C, trinucleotide CGG repeat in FMR1 gene, D is alpha synuclein mutation, and then E is mutation in SOD1 gene. Does anyone have a clue?
Yes, it's
Mhm.
for Huntington's disease
Yes, this is Huntington's. Why do you think it's Huntington's?
because of like 44 years for the symptoms and the similar symptoms for his father who was 45 years.
Mm-hmm. So what specific name do we give to that particular kind of?
Anticipation.
Yes, that is anticipation. So anticipation is very typical of Huntington's. It'll typically give you like maybe a father, mother who has had their manifestations in their maybe 50s, 60s, and then the child typically is going to get those manifestations 10 or so years earlier. Okay, so what is the right answer in this case?
Uh,
A, yeah. Trinucleotide CAG repeats is typical of Huntington's disease, okay, which is caused by a mutation in the HTT gene. The way we can remember the trinucleotide, the specific trinucleotide repeat for Huntington's is, think about a hunter. Yeah? A hunter is going to have maybe a cage for keeping their animals, maybe a dog or even some of the hunted game animals if they're into that kind of thing. So the way you can remember that is cage and Huntington's. Huntington's, cage, CAG, and Huntington's. Okay, I hope it makes sense for you guys. And then B, trinucleotide CTG repeat expansion is in the DMPK gene is found in what condition? Does anyone have a clue?
Friedrich ataxia.
Not really. Friedrich ataxia should be which one on this slide? It should be C, yes, FMR1 gene C. CGG repeats. Okay. CTG, anyone?
I think this will be the shame, maybe. Oh, it's not possible.
No, Duchenne is not caused by trinucleotide repeat expansions. It's usually
Myotonic dystrophy.
Yes, it's myotonic dystrophy. Yeah, myotonic dystrophy. And then alpha synuclein mutation is seen in Lewy body dementia or or Parkinson's disease that comes very early. Typically a Parkinson's should present maybe in 60s or 70s, but if you see Parkinson's in maybe like a 40-year-old, we start thinking about alpha synuclein mutation. Okay, and then SOD1, we've already mentioned SOD1. Does anyone have a clue? Peroxide dismutase mutation. A condition that is characterized by a combination of upper and lower motor neuron lesions. Anyone?
ALS.
ALS, yeah.
ALS.
Yes, ALS. All right, for Huntington's, they get what we refer to as degeneration of their caudate and their putamen. So, what is the right answer in this case?
Yes.
Yes,
It's
it's myotonic dystrophy.
Myotonic dystrophy.
Yeah, myotonic dystrophy. And then alpha synuclein Okay, so this is a typical brain MRI. Okay, but when you see like the left ventricles are like a lot wider, okay, and there is some kind of degeneration of the structures, just usually like lateral to the ventricle, and it's one of those examples, not the only one, but it's one of the examples of conditions that can be characterized by such a finding on MRI. So we've already mentioned some of these things. It's inherited in an autosomal dominant fashion, and there is a concept of anticipation where it appears earlier in subsequent generations. There is going to be degeneration of the caudate and nucleus, the caudate nucleus and the putamen, like in the previous MRI finding, and then they have a triad of movement, cognitive, and psychiatric problems, where the movement is like chorea and dystonia. Okay, cognitive is usually like progressive dementia, and then for psychiatric, they are going to have depression most of the time, but they can also be irritable with personality changes. Okay, and then for management, the medication is usually tetrabenazine or any medication that sounds similar. Okay, and this medication is used to manage the movement problems like the chorea. Right, we've already done this. Well, let me just go ahead and skip it. All right, so for now, for the next slide, we're going to discuss tremors, starting with the tremor that we specifically see in Parkinson's. It's referred to as a pill rolling tremor, and it's usually present at rest. Okay, at rest is very important. And then the tremor that worsens with movement, such as a hand that is trying to reach a target, is referred to as an intention tremor because there is an intention to move, right? And it's typical of cerebellar lesions. And then for the next one, we have bilateral symmetric action tremor. It's also some kind of intention tremor, which improves with alcohol, and it runs in families. It's inherited. That is an example of an essential tremor. Okay, improvement with alcohol is super high yield for essential tremor. Typically, they have to mention it, and the reason why they mention it is because some patients can actually end up just drinking alcohol as a way of trying to cope with their tremor. Okay, whenever they get the tremor, they realize there is an association with alcohol and improvement of their symptoms, so they end up, drinking a lot of alcohol as such. Okay, the next one is fine high frequency tremor that everyone has, and it's enhanced by stressful conditions. Okay, and this is pretty straightforward. This is a physiological tremor. Okay, it's caused by physiological stressors. Okay, right. Next question. 72-year-old man presents with gait instability, urinary incontinence, and progressive cognitive decline. MRI shows dilated lateral ventricles without cortical atrophy. Which of the following is the most appropriate initial treatment? Acetazolamide, ventriculoperitoneal shunt, endoscopic third ventriculostomy, high dose steroids, and then observation only. Okay, this is the full imaging. Does anyone have a clue what condition this is?
It's normal pressure to surface.
Hydrocephalus.
Yes, this is NPH. Okay, NPH is characterized by this wet, wobbly, and wacky. The wet is usually urination, so these patients are going to be incontinent. They're going to be wobbly, so they're going to have balance or gait problems, and then they're going to be wacky, which means their cognitive ability is going to decrease or is going to be impaired. So wet, wobbly, and wacky patient, typically an older patient, and this condition is going to be caused by impaired CSF absorption. Okay, impaired CSF absorption. Okay, hence their ventricles are going to be very wide. This is a lot wider than normal. Okay, going to be very wide, and they're going to press on different brain structures, leading to the said triad. Okay, so which of the following is the most appropriate initial treatment? Does anyone have a clue?
It's like C for the answer. For
C?
Yes.
Close.
Is it a shunt?
Yes, we place a shunt first. If the shunt is not working, that is when we progress to endoscopic management. Okay, so we put in a shunt first. right? And then there is also this concept of temporary improvement of their symptoms with a lumbar puncture. Okay, so that's usually how they do it. They'll do a lumbar puncture. If the symptoms improve, then they go ahead and now put in a more permanent shunt, like a ventricular peritoneal shunt. Right. Next question. 65-year-old man presents with rapidly progressive headaches, personality changes, and right-sided weakness. MRI shows a ring-enhancing lesion with central necrosis and surrounding edema in their frontal lobe. And this is what the gross pathology is showing us. Which of the following is the most likely diagnosis? Meningioma, glioblastoma multiforme,
GBM.
Yes, GBM, absolutely. Okay, GBM. Why do you think it's GBM?
Because of that lesion,
Mm-hmm.
areas of hemorrhage and necrosis.
Mm-hmm. What else? What else that is even more specific for GBM?
The ring enhancing mass.
Ring enhancing mass. Anything else?
Crossing cerebral hemisphere.
Yes, crossing the hemisphere. Okay, I think it's the only one that crosses the hemisphere, at least for the purposes of step 1. Okay, when you see anything crossing the hemisphere, okay, or in other words, they can also say that like it's what is it called? I'm trying to look for the specific term they love using.
Butterfly lesion.
Sorry, butterfly lesion. Yeah, butterfly lesion. Okay, so it's going to have a central necrosis with surrounding edema. Okay, that is GBM. All right. Okay, so to close off today's session, I'm going to show you guys different pathology or histology images for different tumors of the brain, and then you can tell me if you know what they are. Okay, so we have one that is characterized by fried egg appearance, as you can see over here. Let's assume this is like the yolk, and then the rest is the egg white. Okay, fried egg appearance. Which tumor has that appearance?
Oligodendroglioma.
Yes, oligodendroglioma. Okay, small round blue cells that look like lymphocytes that
This is
can.
polycystic for that one.
Ependymoma.
Not really.
Astrocytoma.
Not really. Very close. Starts with an M. It's one of
Medulloblastoma.
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 yes, medulloblastoma. It's one of the neuroendocrine tumors. Actually, most of the neuroendocrine tumors, even the small cell lung cancer, which is of neuroendocrine origin, is going to present like this. Most neuroendocrine tumors have small round blue cells, right? And for medulloblastoma specifically, it can organize itself in form of rosettes. Okay, so these are the round blue cells surrounding this area that is like more clear of the cells. This is another one, this is another one. Okay, those are referred to as rosettes. Okay, which one has a holding pattern? And this is the last question for today.
Samoma for
Me-
meningioma.
Meningioma.
Meningioma, right? Right, so that's it for what I had prepared for today. This is just part 1. Does anyone have any questions regarding the presentation or any feedback?
Thank you so much. It was nice. I just wanted to help me understand the space, separated in space and time, of MS. What does that statement really mean?
Okay, so for MS, MS, like I told you, it's demyelination of the central nervous system, right? So the manifestations, they are going to occur in different parts of the body at different times. Also, for example, they'll tell you that this patient had maybe like optic neuritis, so that she had like the painful vision loss 2 months ago, and now she's coming with weakness in her right leg, and then next year she's going to come with maybe pain in her abdomen. Okay, or maybe hyperreflexia, something like that. So it's manifestations that have different parts of the body being involved and then at different times. Does it make sense?
Thank you so much. It makes sense now.
Okay. Any other questions?
Okay. I would like to know for like other syndrome who have some warmer bodies or those walls.
Apart from meningioma?
Yes.
Apart from meningioma, we have serous, adenoma serous. I'm forgetting the full name of that tumor, but it's a serous tumor
Sister.
of the ovary. Yes, something like that. We can also have the papillary thyroid carcinoma. The other one was mesothelioma, also has these samoma bodies. I can't remember any other. Does anyone else remember the rest? They were like 4, 3, 4, 5.
Okay. So ready to with
Anyone else? It's perfect. All right. Thank you. Okay. So